So Raju, we are good to go. We can start.
Second, Surendra. Just a second. We are live now.
Yeah, we are live.
Yeah. Surendra, am I audible?
Yes, sir. Yes, sir, you're audible. Yes.
Okay, thank you. Very good evening, esteemed colleagues and distinguished panelists and the participants. It is with great pleasure that I welcome you to all this edition of the Cardio Colloquium, held on this 23rd of May. As on today, we gather to delve into an important and evolving topic in cardiovascular care, that is optimal selection of RAAS inhibitors in post-MI patients. Doctors, just to let you know, this is not just a clinical conversation, but a crucial dialogue on improving the outcomes for some of our vulnerable patients, of course, and with cardiovascular diseases remaining a leading cause of morbidity and mortality worldwide, making evidence-based, nuanced decisions on post-MI therapy is so much vital. So we are all honored to have you, us as a panel and highly respected and knowledgeable faculty. Our moderator for the session is Dr. N. Patnaik, whose clinical expertise and leadership continue to inspire. And joining him are the eminent experts, Dr. Rajiv Adikuti and Dr. Suresh Davis, Dr. Sharif, and Dr. Sri Charan Tej. We deeply appreciate their time and commitment to advancing cardiology education. Before we begin, I encourage everyone to engage actively, share your questions, experiences, and insights. Let us make this session as very much interactive and enriching as much as possible. Once again, doctors, on behalf of MCure, welcome to the Cardio Colloquium. Let's begin the journey of learning and exchange with, of obviously, enthusiasm and a purpose. So I would like to hand over the session to our Patnaik sir. Krishan, I think you can share the screen. Patnaik sir will introduce the
Yes, sir.
panel.
Yes, definitely.
Yeah. Also, you can just share, Patnaik sir. I'll just give a couple of brief about if you can share the screen. Okay. Okay, that's fine. If you are not able to share, are you able to share screen? Prashant? Hello.
Krushan, can you share the expert panel slide?
Yes, sir. Yes, sir, definitely.
Yeah.
Actually,
Okay,
Raju, Raju sir,
before you
the
share.
voice was not audible to me actually.
No, I am audible, no? Surendra, am I audible?
Yeah, you audible
Yes, sir.
perfectly.
Now you are audible actually.
Okay. So before I share, anyways, I'll just give a brief introduction of Dr. N. Patnaik, who has got more than 4 decades of experience in cardiology. Doctor was a former professor of cardiology for NIMS Hospital, Hyderabad, and experienced in various cardiac coronary interventions, teaching, and of course, research. Doctor has been having an expertise in interventional cardiology for adults and children, various PTCAs and renal and carotid angiographies. Of course, he's also been a postgraduate teacher since 1999. Dr. Patnaik has also got various research and publications to credit. Nearly there are 50 publications got published in national international. And of course, along with this, there are various reputed certifications and memberships. With this intro, you just take the next slide to introduce the panel. Just keep the next screen, no? Prashant? Sir will introduce the today's panel.
Okay. Yes, sir.
Panel of expert.
Yes, sir. I hope it is visible.
Yeah. Patnaik, sir, over to you.
So Raju, I guess Dr. Patnaik got dropped. He's joining once again. Okay, give a minute. Extreme
Okay.
apologies to the all of the doctors who are watching and the panelists. Dr. Patnaik is joining just shortly.
I don't see Dr. Charan joining. Just check, Surendra.
Was there disruption in the connection?
Sir, we are able to hear you, sir. And just between you drop.
Yeah, okay. Now I'm ready, but is it my turn to start?
Yes, sir. Krushan, if you can share, just sir will introduce the panel. Just
Yeah.
that one slide.
Yeah,
Yeah,
sir.
you can-
I hope the expert panel slide is visible.
Yeah, you can
Not yet.
introduce. Yeah.
Yeah.
Okay. I will
Okay, sir.
I will reshare, sir. Just a second.
If possible, try to reshare. Yeah.
Yeah, definitely.
Quickly. Yeah.
Sir, is the screen visible now?
Go to
Yeah.
full screen. Next slide.
Yes, sir. It is full screen now.
Yes, sir. Over to you, sir.
Yeah, I welcome the expert panel with me, Dr. Rajiv Edukuti, Dr. Suresh Davis, Dr. Sharif, and Dr. Sai Sri Charan Teja. Today's topic is about management of post-MI patients, especially those with LV dysfunction and who are potential to go into heart failure. As you all know, in acute MI, the first and foremost thing is revascularization. If it is done efficiently, probably there will not be much LV dysfunction and heart failure. However, it's logistically not always easy to offer effective revasculation in time. So we do get about 15 to 40% of our patients will have large myocardial damage and they go into heart failure subsequently. So at the time of admission itself, about 3 to 4% will be in heart failure and about 25 to 30% may subsequently develop heart failure. And if they are in shock, there is no option but to support them with mechanical supports. And among the various medications that are used after acute MI are well known to you, that is antiplatelets, anticoagulants, nitrates, diuretics, intensive statins, and of course, gradually you have to introduce RAAS inhibitors, beta blockers, MRAs, and SCLT inhibitors. Of course, you should also treat the comorbidities concurrently. Which subset of patients are more likely to have heart failure? Those who have got high risk factors like age more than 65, previous MI, or ejection fraction less than 35%, those who have acute kidney injury, and
Sir, sorry to interrupt you. We cannot able to see your slides, sir. Please share.
yeah, sure.
Krushan, you stop sharing your
Yes,
this
sir.
thing.
Done.
Interesting. Yeah.
Yeah. Are you seeing my slides?
Yes, sir. Please keep it full screen, sir. We are able to see.
Yeah. Is it full screen now?
Yes, sir. Go ahead. Thanks.
Yeah. Yeah. I just was talking about the management of heart failure and which subset are more likely to go into heart failure after post-MI situation. Those who are above 65, diabetic patients, those who had previous MI or where renal dysfunction is there, or those who have raised uric acid levels or elevated BNP. These are the subset who are more likely to go to heart failure. So invariably, we have to start with AC inhibitors, optimize, and add beta blockers, then MRAs within first 1 week. Then nowadays, SGLT2 inhibitors are also recommended as early as possible. So this is the main four-pillar approach to the post-MI LV dysfunction management. Let us look at what happens with what is the evidence to use various molecules. For RAAS inhibitions, we have AC inhibitors, ARBs, and of late RNA. So our focus of discussion will be mainly about RAAS inhibition. As early as 2002, there were two important trials, Optimal trial and Valiant trial, which have studied losartan and valsartan in large number of patients. And losartan has not shown, captopril was tried in Optimal trial, and it did not give much benefit as compared to standard therapy. But valsartan was also as good as captopril, especially in the high-risk patients. And a combination of valsartan and captopril was also tried, but it did not improve the survival further. So optimal trial was perhaps the one of the first trials with ARBs and SE inhibitors. Prior to that, there are trials like SAVE trial, AIR trial, and TRACE trial. These are all SE inhibitor trials. We'll go to them subsequently. I would like my panelists to answer me. Is there any role valsartan in the present day post-MI patients? Are we using? What is your experience? Any of the expert panel members can tell. Dr. Rajiv.
Sir, I didn't get the question. You said valsartan in heart failure.
Yeah.
Yes, it is. See, in heart failure, as we
In
well know,
post-MI situation.
post-MI. No, post-MI, everywhere, see, the discussion is on post-MI heart failure if it's a large anterior location in patient with heart failure. The idea is to start targeting renin-angiotensin system early. So you have to start early. And the recommendation is to start an ACE inhibitor. And if not tolerant, or if you cannot, alternate is an ARB. So in post-MI setting, the first option is always in literature because the number of trial data favoring ACE inhibition is much more than ARB in that setting. So the recommendation always and our practice always has been to use ACE inhibitor in post-MI, especially if the patient has established heart failure or the patient is at risk of heart failure. Even if the patient has a large MI and even the EF is normal, that person comes as a risk for heart failure group. In that subject also, I think the recommendation is to attack renin-angiotensin system with ACE inhibitor upfront, if intolerant, or if you are worrying too much on hemodynamics, then as an alternate to ARNI. But the evidence is strong in ACE inhibition.
Thank you. Thank you. taking in general, RAAS inhibition actually modulates the LV remodeling and LV dilatation and thus prevents precipitation of clinical heart failure. It reduces arrhythmias and it is beneficial by way of mortality benefit also. So, as Dr. Rajiv has said, AC inhibitors and ARBs have been tried earlier and they are accepted in our day-to-day practice. Then came ARNI. ARNI has been in discussion for last 1 decade or 12 years. And there are a number of trials which have given a lot of support for the use of ARNI in chronic heart failure, where there is reduced ejection fraction. So ARNI has become even class 1 recommendation for chronic heart failure, along with beta blockers, MRAs, and SGLT2 inhibitors. After its success in general heart failure management, there was thought whether it should be used in post-MI heart failure as well. So a large, well-conducted trial has been designed and very well executed and analyzed. That is Paradise MI trial. This was presented in ACC 2021, but I'll come to the discussion and conclusion a little later. It included all the acute MI patients from 12 hours to 7 days, wherever there is ejection fraction less than 40%, and there was clinical evidence for heart failure, plus any of the risk enhancers. Risk enhancers are age more than 70, EGFR less than 60, diabetes, prior MI, atrial fibrillation, ejection fraction less than 30%, KILIP class 3 presentation, or STEMI without reperfusion. Of course, they have excluded prior heart failure, clinically very unstable patients, and where GFR is less than 30. They had two arms. One is ARNI, that is sacubitril valsartan group. Other is ramipril group. They almost had equal number of patients included, and they looked at the primary events of CV death, heart failure hospitalization, and OPD development of heart failure, and secondary events were CV death or first heart failure hospitalization. So these were the hard points they were looking at, and the primary outcomes were analyzed. To the surprise of the investigators, it was seen that the comparison was with ramipril 5 milligram twice versus sacubitril about 200 milligram BD. But there was no statistical difference, significant difference between the two. So sacubitril valsartan did not fare superior to ramipril. So when you take all the primary outcomes together or individually, sacubitril and valsartan did not fare better than ramipril. This became a big discussion of the scientific committee, scientific fora, and they looked at the adverse effects. Fortunately, sacubitril and valsartan versus ramipril, the adverse events were not too different. The hypotension, incidence of cough was slightly higher in ramipril, but renal impairment, hyperkalemia, liver dysfunctions, these are all equivalent. In summary of Paradise MI trial, sacubitril and valsartan did not result in significantly lower rate of death or heart failure hospitalization or outpatient heart failure requiring treatment. And there is safety and tolerance wise, ARNI was as safe as any other heart failure patients. So at least that was proven, but it did not reduce the hard cardiovascular events. And there was a lot of editorials and discussions in the scientific fora. If you look at the headings, Paradise MI, sacubitril valsartan cannot beat ramipril, Medscape has said. ACC, Paradise MI did not outperform AC inhibitors. Faraday's MA makes me question the sacubitril valsartan. Like that, they are very thought-provoking and critical headings in all many articles that came. So, looking at years-old AC inhibitors, SAVE trial was the earliest one in 1992, followed by AIR trial and TRACE trial almost 1 or 2 years after that. And at the same time, there were some more trials which have looked at short time benefits like consensus 2 in enalapril, GC3 and ICS4. SAVE trial is a very landmark trial because here, when compared to placebo, the captopril curve was definitely deviating, showing that over 3 to 4 years, there was 19% reduction in mortality and 25% reduction in recurrent MI. So there was every reason to use captopril in post-MI heart failure patients. Then it is followed by another molecule that is a TRACE trial, trandolapril, and it was also very favorable over 24 to 50 months of observation, 25% reduction in mortality. Then there were other evidences like ICS4, GC3, and CCS1 with large populations which have shown the benefit of captopril, lisinopril, and so AC inhibitors and ARBs. Now ARBs are to be used only when AC inhibitors are not tolerated, have become standard of therapy for post-MI, LV dysfunction and heart failure, especially in those who have high-risk predictors for heart failure. A trial is another landmark trial in 1993, acute infarction ramipril efficiency, where the ramipril curve has significantly deviated with a relative risk reduction of 27% over observation of 15 months. There was 27% reduction in mortality. And this gave a big boost to the ramipril, and it has become the molecule of choice for post-MI patients in both in acute stage as well as in the long run. AIR extension study has further given evidence that over observation of 5 years, though this observation was in a small group of patients who participated in AIR, there they have seen that beneficial effects started early after MI and they persisted even after 4 years, despite discontinuation of the medication after 1 year. That means if you are giving for 1 year, after that patient is a little bit irregular with ramipril, still the legacy effect is still persistent even at the end of 4 years. And there is one more AIR survival study which was done in 2021, which is almost 30 years of observation on ramipril in post-MI heart failure. It has shown that the life expectancy has increased and all-cause mortality has come down. You can look at this curve where there is an extension of 14.5 months by using it for 15 years. So this is a very big boost, and you can continue ramipril for even for 15 years safely, and you can get sustained benefit. And if you subsets, if you look at like diabetic subset, previous MI subset, or previous history of heart failure, hypertensive subset, those who are symptomatic, or those who are above 65, in all these subgroups also, the similar difference in the benefit in the ramipril group as compared to placebo group. So for every day a patient receives ramipril on an average, his life is extended by another 1 day. So relative risk for survival in patients with diabetes was increased by about 54%. And patients with diabetes, those who had previous MI, previous heart failure, hypertension, and angina. And if they are given ramipril for about 1 month, 1 year, and it is continued, there is an extension of life for another 1 year additionally. So this is a wonderful effect, not seen with many of the molecules in any of the cardiac conditions. So treat with ramipril for about 1 year, start early, continue for at least 1 year. There will be additional life of additional 1 year. So at this stage, I will ask my panel members to kindly opine on the trials with ramipril and other SE inhibitors. Dr. Sharif, can you give your comments on these trials, which were landmark trials?
Sir, this is a undisputed area that the role of ACE inhibitors has a significant effect in the patients with MI and LV dysfunction. And among all the molecules that are available for this heart failure following in MI, the most robust data is available for ACE inhibitors. This has been around for several decades, and we know the longest follow-up data we have. So this is totally an undisputed area. So all the patients who have suffered an MI and there was evidence of pulmonary congestion or LV dysfunction must be initiated on ACE inhibitor within the first 24 hours unless there is a contraindication. We all know that hemodynamically unstable patients or who have renal dysfunction, these are the patients who are excluded from majority of the landmark trials. In all other patients who have an MI and LV dysfunction must be started on this ACE inhibitors unless otherwise contraindicated. And it is also to be noted that these drugs must be continued indefinitely because recent data have shown that if you discontinue ACE inhibitors following the recovery of an LV function, again there is chance of worsening of the LV function. So beyond 1 year also, these patients must be continued on ACE inhibitors unless there is a significant contraindication for this.
Thank you. Dr. Suresh, any comments on long-term use, especially in view of the AIR extension study?
I also personally agree to the fact that this should be continued lifelong rather than stopping at 1 year, because the benefits will always, ultimately for the AIR people there was benefit, but I personally believe it should be started for a long period of time. It should be treated indefinitely, and definitely in a ischemic setting, definitely ACE inhibitors have got more data compared to any other agent.
Dr. Sai Charan, why do you think ARNI was not so beneficial in post-MI situation? And what are your comments on practical difficulties in using ramipril in your practice?
Good evening, sir. Basically, ARNI in a MI patient, it is beneficial as soon as we start ARNI if there is no contraindication or patient's hemodynamic status is normal, like he's not in shock or no acute kidney injury or any kind of renal illnesses. Unless until it's contraindicated, it is the first drug to be started in post-MI patient, even before even the irrespective of the revascularization status is the first drug to be started.
Yeah. No, about Paradise MI trial, you have any comment why it is not as robust, benefits are not seen as in regular chronic heart failure? Do you think the mechanism may be different in post-MI heart failure? That's why. Yeah, possibly. Yeah, this is one slide which is showing the time-dependent therapies in post-MI heart failure. When the index MI has occurred, it is always ACE inhibitors should be tried to be introduced within first 24 hours. If the patient is not in shock and irrespective of the revascularization, probably we have to start within the 24 hours. After you are sure about the decongestion, after you are sure about absence of shock, that is systolic blood pressure is reasonably okay, then we start with a low dose and up titrate. Once the 24 hours are over, then if there are no contraindications, that's the stage when we have to introduce beta blockers, which are indicated for heart failure. And within first 7 days, it is advisable to start aldosterone antagonists. So there are number of studies saying that earlier you start SE inhibitors, earlier you introduce beta blockers, there is mortality benefit and there is a favorable left ventricular remodeling and prevention of heart failure. Then, of course, you can add a number of other molecules depending on the profile of the patient. So this is the timeline which is recommended. So there is an important post-MI heart failure state of heart review in JACC, which has clearly shown that SE inhibitor should be administered within first 24 hours if the ejection fraction is less than 40%, or in heart failure patients with significant survival benefit is conferred if it is started on first day itself, and early initiation is very important. The contraindications mentioned by them are systolic blood pressure less than 90 to 100, shock or acute kidney injury, renal failure, or drug allergy. So this is a message from the JACC review. Then ESC in 2020 has recommended that irrespective of whether it is ST elevation MI or MI without persistent ST elevation, SE inhibitors or ARBs in case of intolerance to them is recommended in heart failure with reduced ejection fraction or when there is chronic kidney disease within manageable levels. So this will reduce all-cause mortality and cardiovascular mortality and morbidity. So it is a class 1 indication according to ESC guidelines. Even in February 2025, there were guidelines released on ACS and heart failure. If you look at various recommendations, in high-risk patients with ACS, where ejection fraction is less than 40%, if there is hypertension, if there is diabetes, or STEMI in anterior location, or a SE inhibitor or ARB should be indicated as class 1 recommendation. It is the level of evidence is A. Of course, if the mineralocorticoids are also class 1 indications, but after 24 hours. Nowhere you see the mention of ARNI in this particular recent guidelines. So ARNI is not a molecule to be chosen in post-MI situation as per the recent guidelines. So let us come to a few of questions which I will request the panel members to answer. Dr. Rajiv, in post-MI patients, after revascularization, at what systolic blood pressure you will be comfortable to start SE inhibitors? What is the starting dose? How will you titrate?
Okay. As already, sir, you have shown in the last slide that a systolic BP of 90 to 100 is acceptable to start ACE inhibition. So I also concur. I am not. If I would put it as in my personal choice to be 100, not 90. I put it as 100. So any patient who has a systolic BP of 100 and beyond, I would consider starting an ACE inhibitor therapy as mentioned in the first 24 hours itself. So that is the dictum. Unless a patient has atrial fibrillation with fast ventricular rate, and such a patient who would benefit specifically from beta blockade early, all other patients would be candidates for ACE inhibition in the first 24 hours, preferably ACE inhibitor if systolic BP is more than 100. Now, the starting dose I would recommend is depends entirely on how the hemodynamics is. If the patient is hypertensive, if the patient was taking an ACE inhibition in the past, then I would confidently go with the tolerated possible maximum dose, higher dose straight away itself. So a patient who is hemodynamically on borderline or compromised, my preference is to start with lower dose of, see, we have agents available like captopril, enalapril, and ramipril, all these things. So
Ramipril 2.5 is okay, or
yeah,
still less?
ramipril 2.5, the standard recommended dose is 2.5 milligram of ramipril or enalapril to start with. Interestingly, the ramipril comes with a strength of 1.25 milligram. That is actually for, it's interesting that no other drug has such a lower dosage. So this is convenient if a patient is really intolerant or hemodynamically unstable. You can start with low dose. I'm not sure the benefits are so huge, but you can start. So I would prefer to start at 2.5 milligram daily. And how to uptitrate the dose? Again, that depends on two parameters. One, hemodynamic improvement, as well as renal function monitoring. These two. So a patient who has stable renal function, it should be gradually uptitrated from the starting dose of say 2.5 to 5 milligram gradually. See, when I say gradually, it means, see, we have seen that first we have to start ACE inhibitor. Now the next step is we have to reduce nitrates, you have to reduce diuretics. Once a patient improves, then we can confidently go on hiking the dose of ACE inhibitor, because once hemodynamically we can safely give higher dosage, that is better. So I would go start as lower dose ACE inhibition after first 24 hours. Next day, I would try to start a low dose beta blocker, then come back to ACE inhibitor, uptitrate, try to reduce diuretic on the day 3, day 4, and then gradually go to say 5 milligrams ramipril. And beyond 5, I just go a little slow. I don't, in our population, I don't think beyond 5 milligrams ramipril, it is not safe to increase in all of a sudden, unless the patient is really hypertensive. I think I have answered the question. Yeah.
Yeah. One comment. In practical problem which I face, most of my patients are discharged around 5 milligrams if they tolerate. Once or twice is the maximum dose. Most of them are discharged. But once they go to the periphery, the district level or village level, physicians tend to reduce it, telling that your BP is low, so much dose is not necessary for you. This is a very common experience. What about you? Any comments from the panel?
Yes, it holds good not only for ACE inhibition, it holds good for ARNI, it holds good for beta blockade, all these drugs. We have to educate people that these are not for your hypertension. See, people have a tendency to pick drugs and say one is for blood clotting, one is for cholesterol, one is for blood pressure. No, we have to educate them. That's the only way, I think.
Yeah, that's. Dr. Suresh, you have any comments on this particular issue?
Yeah, this is the same issue everybody is suffering, because the cardiologists are very fond of all these agents and we saw the mortality benefit. But when ultimately it comes to physicians, they always try to reduce the medication. Not only this, even statins also, we try with high dose statins, try to keep the LDL as low as possible, 55 and less. And once they see this value, and something that is happening is that these people go for investigation. So the laboratory people also make a fuss of things, especially when they see low LDL cholesterol. They say, your cholesterol are very low, go and meet your doctor. So patients are getting scared.
Yeah, it needs a lot of education. Yeah, right. Dr. Sri Charan, can you tell me, will you switch the patient to SE inhibitor if the patient was on some ARB before? Suppose hypertensive, it's common to use telmisartan, olmesartan, and he sustains an MI. Do you change to SE inhibitor or continue the same?
Sir, if there is if the initially why they have started on ARBs, it's because of
Usually for
some
hypertension, they
contraindication.
say, yeah.
Yeah, if there is any contraindication with respect to AC inhibitors or any side effects to AC inhibitors, and in that condition, if they would have started on ARB, I will try to go with ARB itself. Otherwise, there is no problem to start a AC inhibitor for a patient who is already taking ARBs. Even all the trials also suggest AC inhibitors are equally effective even to the ARNIs in cardiovascular point of
Yeah.
thought, sir.
Dr. Sharif, any viewpoint from you?
Generally, I tend to not change the drugs. The patient is on the chronic medications, especially in a post-MI setting. I usually try to minimize the manipulation of drugs if the patient is already on a RAAS inhibition. For a RAAS naive patients, of course, the first choice comes as ACE inhibitor. Otherwise, I usually tend to continue the same ARBs.
Yeah, that's it. Yeah. There is some individual difference in practice. Ramipril has the strongest evidence for post-MI LV dysfunction and heart failure. But anyway, I think it's all class effect. Most of it is class effect.
May I just give one comment on this?
Yeah,
See,
sure.
basically, the hypertension. See, we know that
Yeah.
for the better drug for a very hypertensive patient, for hypertension control, is ACE inhibitor compared to ARB. That is a
Yeah.
fact. See, for higher blood pressure, so those patients who have very high blood pressures, a patient is in the past was on ARB, a fairly good dosage. I think that would be worthwhile to shift to ACE inhibitor in post-MI setting.
Yeah, thank you. How early do you think ARNI should be initiated in a post-MI situation? It should be at all be given? If at all it is given, how early? Sharif, sir.
Yes, again, the question should be whether it should be chosen as the first choice following post-MI. This is the question. But anyway, if you decide to start on ARNI, I think the time of initiation does not vary much from the AC inhibitors, because the idea is to block the AC RAS inhibition as early as possible following an MI. So it should be within the first 24 hours unless there is a contraindication. So since the trials have shown there is a statistically significant increase in the incidence of hypotension following the RNA initiation, so it would be wise to start with a very low dose, probably 50 mg BD or 50 mg, even half of 50 mg BD with RNA, and then very slowly update the drug. The question is whether they should be preferred as a first-line drug when compared to the AC inhibitors. Probably if the patient is already on AC inhibitors, it should never be switched to an RNA, especially in this setting. For an AC naive patients, again the preferred drug is AC inhibitor, but starting RNA will not be a bad choice, because I have some difference of opinion here, because Sir has asked whether why this particular drug has not worked in the newer trial. Probably because here the comparison when compared to the the paradigm trial, the comparison was with RNA versus enalapril 10 mg BD. So most of the target dose of the enalapril is actually 20 mg BD. So here the comparison was with RNA versus Ramipril 5 mg BD. The target dose of Ramipril is 10 mg per day. So if we see that the paradigm trial has shown much benefit, probably because the enalapril was not adequately maybe given here, the RAS inhibition was given at a very complete dose in this paradise trial. I don't know, probably that may be one of the reasons why this particular drug has not shown any superiority when compared to the Ramipril in the post-MI setting.
About Paradise MI trial, I had been listening to some experts. What they say is probably post-MI situation, the neurohumoral changes haven't occurred or established yet, like chronic heart failure. So ARNI may not be so effective because the mechanism in post-MI situation is more of LV remodeling and dilatation rather than neurohumoral dysfunction. That's the explanation by some of the experts.
Interestingly, the paradigm trial also, if you look at the 40% of the population actually had a history of myocardial infarction, even the paradigm trial.
Yeah.
Probably in the long term, whether the curves will diverge or not, I'm not sure.
Yeah, this question is to Dr. Suresh. Post revascularization, if you find LV systolic dysfunction less than 40% of ejection fraction, but clinically the patient is stable and no signs of heart failure, how will you approach him with respect to RAS inhibition?
As already clearly mentioned in your slide, sir, it is a class 1 indication to start AC inhibitors when it is fraction less than 40%. So as beta blockers and aldosterone antagonists. So it is an indication if the VF is not less than 40%, we should start on all these medications according to starting with a ACE inhibitor followed by a beta blocker and a aldosterone antagonist. RNA I don't think has any role here because the patient has no heart failure and post-vascular situation.
Yeah, I think the audience should be clear that even if there is no clinical heart failure, the patient is dry and stable and mobile. If the systolic blood pressure is less than 40, especially anti-reval MI in presence of diabetes or chronic kidney disease or history of previous MI, all these high risk factors are there. It's always better to give RAAS inhibition, preferably AC inhibitors. Then in post-MI patient, post-revascularization, what about starting beta blockers? How comfortable you are and what dose you start? How will you titrate? Rajiv, can you tell?
Yes, after the first 24 hours of, over and the patient is relatively hemodynamically stable, and I think that's the best time to start. After ACE inhibition, I think it is best time to start a beta blocker. And the preferred beta blocker I use in acute MI is metoprolol. That's my personal choice. There is no harm in using carvedilol. There are enough data for carvedilol. There is data for bisoprolol. No, MI. This is my personal choice because I can titrate it easier. I can up titrate dose according to heart rate. So that is my preferred choice of beta blocker. And the up titration of beta blocker is again basically on heart rate and blood pressure. The dictum I follow is to start ACE inhibition first, then give beta blocker, then go back and up titrate ACE inhibitor next, and then come back to beta blocker and try. So not go one drug at a time and then try to increase to maximum tolerated dosage. One thing here is in a patient who is on beta blocker plus an ACE inhibitor or ARB. So these patients, they see when I shift them out of ICUs, and what I usually do is you should have them walk a little. See, there should be beta blocker. We cannot just go by the resting heart rate alone. The patient may have a heart rate of say 50, and he's probably getting the smallest dose of beta blocker. But on walking, so I am talking about patients with heart failure, patients with MI post revascularization. On walking, their heart rate may go up to 80, 90. So such a patient, I would up titrate beta blocker depending on ambulatory. When the patient have a 5 minutes walk pre-discharge and up titrate beta blocker. Now, the last question I think is ACE inhibitor and beta blocker combination. I think is it referring to a fixed dose combination or something like that? Then I don't know. Otherwise, ACE inhibitor and beta blocker are standard. I think it's a question for a fixed dose combination. I don't think fixed dose combination has no role in an acute hospitalized MI patient setting.
Yeah. Other panel members, you have anything to add on this issue?
If you ask me, beta blockers, I used to use metoprolol as already mentioned by Dr. Rajiv, but nowadays I'm changing to bisoprolol because heart rate control is better with bisoprolol in the lower dose, and there is less the hypotension noticed with bisoprolol. So the rate control is very nice with the bisoprolol. So
maybe metoprolol, extended release, carvedilol, and bisoprolol are equal choices. Depends on what you are comfortable with. There is.
Yeah, I used to be metoprolol commonly, but nowadays I have made a small change towards bisoprolol because of the weight control. And the newer trials are in favor of bisoprolol.
Yeah. Okay, thank you. Dr. Rajiv, again, do you think we should do anti-pro-PNP and based on that decide what to use, Ramipril or Harney or like that?
Yeah, it's a little confusing question because see, NT-proBNP is very well established in the setting of heart failure. I'm not talking about acute MI setting, heart failure. No. Yeah. In chronic heart failure setting, it is very well established, and in all I think one of the area where ARNI shows superiority over ACE inhibition or ARB is in reducing NT-proBNP level with treatment. And we all know that NT-proBNP is a strong predictor of adverse events, especially mortality and rehospitalization. So in if one area where ARNI has an edge over ACE inhibition is a patient who has high NT-proBNP. This has been validated well in heart failure trials, in chronic heart failure trials, and that is possibly one reason why it is the recommendation over ACE inhibitor ARB in heart failure. Now, coming to acute myocardial infarction, the results of NT-proBNP, I think, are a little conflicting. I don't have experience in doing in acute MI patients. I don't do NT-proBNP or BNP in acute MI patients, and saying. But then theoretically, that question, if there is data that a high NT-proBNP level in a heart failure patient, in an MI patient, even post-revascularization, at the outset of MI or even pre-discharge, the patient has worse outcome. So such a patient, I would say, and not in the acute first initial period of MI, but pre-discharge, if a patient has high NT-proBNP, then I would prefer to decide in favor of an ARNI over ACE inhibitor in that setting. But I don't have a very straightforward answer in acute MI setting and doing NT-proBNP. I don't know.
Dr. Sharif or Sricharan, any views on that?
So again, this NT-proBNP is not a, I don't think it is a mandatory molecule to decide on the molecule of therapy. Because all heart failure patients are expected to have a high BNP levels. All ANP BNP levels must be high in a patient who has a significant LV dysfunction. So irrespective of the levels of the natriuretic peptides, all these patients must be started on the therapy. So the decision of choosing a drug one over the other, I don't think it should be based on the particular molecules, and it is not also practically feasible. You cannot do pro-BNP in all the patients who have a heart failure. I think this molecule is mainly for to assess the therapeutic effect of the drug. Probably if you do a follow-up study and we can know whether the BNP levels are significantly coming down, then we can actually. I don't think this should be done in a patient who has an LV dysfunction to decide on the therapy.
Thank you. Sricharan, will you start SE inhibitors in patients with ACS, whether revascularization was performed or not, just to get mortality benefit? Yes.
Yes, sir. I'll start, sir. Hello.
You look at any parameters or just everyone you want to start? Do you want to start for everyone or any parameters you follow? Probably we'll look at ejection fraction.
I couldn't hear.
Yeah.
Don't know.
Yeah, it has the mortality benefit, especially those who have ejection fraction less than 40% diabetic patients. Even if they're going for revascularization or not, it is a good idea to start SE inhibitors. What percentage of patients tolerate ARNI 200 BD versus Ramipril 5 BD? Because this was the 2 arms and dose which was given in Paradise MI trial. This particular question comes.
But to be honest, none of my patients are actually taking 200 milligram BD of ARNI.
Yeah.
Majority of my patients are just stuck to 100 milligram BD to the maximum.
Yeah,
A
that's
few
the
patients
experience.
Sure.
Rarely they go to that high dose, either because they have the impression that they can't tolerate. Second is cost itself. 200
Yes, sir, there are
BD is
several
quite
factors.
high.
That's what I am going to say. It's not purely because the patients are intolerant to the medication. In my experience, mainly because majority of the patients do well with 100 milligram BD. So I just stop with the drug. There is a reluctance on my part also to escalate the dosage.
Yeah.
And some patients, of course, severe LV dysfunction patients who have recurrent electrolyte disturbances, who have a borderline renal functions. For those patients, they are started with 15 milligram BD. So personally, I do not have any patients who are actually taking 200 milligram BD of ARNI. Of course, Ramipril 5 mg BD is majority of the main patients are taking 5 mg BD and they do tolerate well.
Yeah. Dr. Suresh, any views?
Few of my patients are taking RD 200 milligram twice daily. So it's not every patient, it is maybe 5 to 10% of patients. Some young patients with hypertension are able to tolerate higher dose of RNA. It is not a one-day process. We are stepping out with lactate, jump, half BD or 1 BD, and then you step up to 100, and then you wait for a period of time, how response. If the BP is still high and goes, it is possible to increase to 200 milligram BD without much difficulty. Only thing is that you have to, it's the initial dosing which has the most difficult. I found that. When you start a 50 mg half BD, maybe patient go into hypotension. But when you start tightening upwards, it is not causing so much hypertension as we are feeling.
Right. Anyway, this was the last question. If any of you have anything to add to the discussion so far,
Yes,
we'll
the
discuss and then-
last question, as Sharif said, it is, my experience also, I have less than 5%, very few patients are on 200 BD of RNA. Even though, I have tried in few patients and people few patients have tolerated for 200 BD to the very well also. But what happens in most of them, and I'm saying few of them, most of them is, I have to see these patients walking around with 80, 70 systolic BP, even if they are not symptomatic or intolerant. It has been said that they are happy about it, being happy hypotension and all these things, terms are there. But then you are not comfortable in outpatient setting. People come with an 80 systolic BP and they are okay, no symptoms.
That's true.
We are not, we are not comfortable in continuing in that dose with that. That is a fact.
Yeah. Are there any more questions? Or audience questions in the chat box?
Prashant, are there any questions by delegates, the attendees? Just check in the chat box.
Sir, there are no questions as of now.
Okay, sir. I think then in that case, I think more or less we have addressed throughout the discussion, only panel discussion. You can give your final comments and we'll close with vote of thanks. Yeah.
As you all know, post-MI patient is a very tricky patient. Acute management depends on how he reaches the hospital and what is the expertise and what is the affordability of the patient. And revascularization stands the best strategy for reducing the mortality and preventing heart failure and further arrhythmias. Among the medications, SE inhibitors stand tall based on the evidence since the days of SAVE trial, followed by AIR trial and AIR extension trial. And of late, though RNA is promoted as class 1 molecule for chronic heart failure, not in acute MI situation, it has not proven its superiority over ramipril in Paradise MI trial. So if carefully started and titrated within the first day of MI, it will give very perceptible mortality benefit and morbidity benefit at a very low cost. And the molecule is well tested and most of the physicians are comfortable in starting it, titrating it and continuing for years together. Whereas there is no evidence for RNA, ARB is reserved for those who cannot tolerate SE inhibitors by way of cough or other side effects. ARB is a substitute for SE inhibitors. Then, of course, MRIs and beta blockers have their own specific role. They should be introduced as a part of the package for long-term management of heart failure. And our aim is to prevent precipitation of severe heart failure and continuing heart failure. That is the aim. And to this respect, ramipril is a great molecule to use. Thank you all for very wise discussion.
Thank you.
Thank you, sir.
Yes, sir. Thanks, sir. Krishna, am I audible? Yeah.
Yes, sir.
Okay. Good evening, everyone. Once again, doctors, as we come close to the today's enriching session, I would like to take the opportunity to extend my heartfelt thanks to all who made this event a successful one. And Krushan, can you tell what is the delegates number pan India today?
Yes, sir.
Approximately?
We have crossed more than 400 delegates sir, today.
Okay, sir.
That's good.
Okay, thank you. That's a good number, and thanks a lot for first of all taking this number across pan India. Many doctors have attended. Doctors, first of all, my sincere gratitude to our moderator, Dr. Ian Patnaik, for guiding the discussion so effectively, and to our expert panelists, starting with Dr. Rajiv Edakuti and Dr. Suresh Davish, and followed by Dr. Sharif and Dr. Sri Charan Teja, for sharing their valuable insights on optimizing RAAS therapy post-MI patients. A special thanks to all the participants for your active engagement and thoughtful, of course, the questions which have been shown with the involvement truly adds value to these discussions. Lastly, thanks to my MQ colleagues for getting all the delegates from Pan India, and the technical support for ensuring everything ran so smoothly. We look forward, doctors, to seeing you once again at future sessions. Until then, stay safe and stay inspired. Thank you, and good night from Team MCure. Thanks a lot,
Thank you.
doctors.
Thank you. Thank you very much.
Thank you. Good night.
Thank you so much, sir.
Thank you all.